Very good morning, all. Today I'm going to present Journal Club Anxiety among pregnant women during the COVID-19 pandemic in India. This is a multi-centric study. Authors, corresponding author Dr. Pratima Murthy, who is a director and professor HOD of Department of Psychiatry in NIMHANS, and Dr. Sai Krishna sir and others. In the year of 2021, the paper has been published. Keywords: pregnancy, antenatal, anxiety, COVID-19 pandemic, risk perception, and social support. There are 7 keywords were used, and 5 centers has been selected for multi-centric study. And AIIMS Raipur, Sri Guru Ram Rai Institute of Medical Sciences, and our institute, and High Tech Medical College, Bhubaneswar, Lady Harding Medical College, New Delhi, and Jain Medical College, Raipur. Among five centers, 3 centers are government colleges and 2 private colleges are included. This is the original study, hospital-based cross-sectional study. This paper has been published in Asian Journal of Psychiatry. Impact factor 13.89. Introduction. Across all 3 trimesters, pregnant women are at risk for anxiety disorders of varying severity. Global prevalence of anxiety disorder 22.9%, also very close to the psychiatric disorders in antenatal women in India. According to data from India, while some anxiety during pregnancy is considered as normal, higher levels of anxiety that necessitate clinical attention are not uncommon. In fact, pregnant women have higher rates of certain anxiety disorders than the general population. Pregnancy specific anxiety, specifically linked to worries, fears, and pregnancy, childbirth, like tocophobia, infant health, and parenting. Antenatal women with anxiety disorder had met various risk factors such as strained marital relationship, poor social support, domestic violence, lower education, and unemployment. Once it is not treated properly, this can develop other psychiatric and neurotic issues among the mother and child in future. Past researchers, meta-analysis done with 35 relevant studies, also added in the supplementary article in the study, suggesting the prevalence rate of anxiety among pregnant women during the COVID-19 pandemic of 42 to 43%. Aim of the study to assess anxiety that is specific to the composite context of COVID-19 and pregnancy in addition to generalized anxiety. Secondary aim of the study, determine the various demographic and clinical predictors of generalized and antenatal COVID-19 anxiety. Further, they were assessed to the role of perceived social support and risk perception of COVID-19. Materials and methods. This is a hospital-based cross-sectional study carried out in a multi-centered tertiary care teaching hospital, included 3 government institutions and 2 private institutions in India. Approved by Institute Ethics Committee, AIIMS Raipur. Patients included after obtained written informed consent. Inclusion criteria: women those who are attending antenatal clinic with the help of Department of Obstetrics and Gynecology. We confirmed the pregnancy with a gestational period before 36 weeks. Sample has been selected, and written informed consent for this study has been selected. Exclusion criteria: those who have psychiatric illness in the current situation included in from the study. Procedure: before the data collection, uniform standard operating protocol was followed. The residents, Department of Psychiatry as well as Department of Obstetrics and Gynecology were shown a Hindi video of an example interview, so they could be trained and have it ready for when they were conducting the interviews. And the demographic and the clinical information, both obstetric and medical, were recorded following the receipt of written informed consent. Procedure: this is mentioned in the supplementary article. Number 1, antenatal checkup completed by the obstetrician and by PG interns as well as obstetrician practitioner, and the introduction of psychiatry related to the obstetrician was followed, and handing over the participation recruitment sheet PAS to the handover to the resident after assessed possible recruitment, and consent were taken with a signature of left thumb impression. Socio-demographic data tools were applied and recorded. All the collected informations, scan and photograph, and uploaded to the concerned email and sent to the email ID on daily basis. COVID-19 safety precautions were followed during the interview and completed within 20 minutes. Tools used. COVID-19 lab test was recorded as per ICMR procedure protocol, and the scale, generalized anxiety disorder scale and antenatal COVID-19 scale, and for psychosocial risk evaluation pregnancy scale, maternal version applied and translated as Hindi as well as Oriya language. Statistical analysis. The obtained data were analyzed using descriptive statistics such as frequency, percentage, mean, and standard deviation. Frequencies were calculated for assessment of the prevalence of generalized anxiety based on cutoff scores. Mean, standard deviation were calculated for the scores on various scales. The one-way association between demographic and clinical variance been assessed like scores of perceived social support, COVID-19 risk perception, antenatal COVID-19 anxiety, and the generalized anxiety was assessed using chi-square test and the t-test. A multivariate mixed models MANOVA analysis was conducted to assess for predictors of generalized anxiety and antenatal COVID-19 anxiety, and the two separate levels for generalized anxiety disorder and antenatal anxiety was assessed. Results. Total 750 women were approached, but finally 620 patients were selected for the study. Mean age of total sample was 26.36 years. Majority of the sample were Hindu religion, almost married and staying with their husband. All the people were educated up to high school or above. Most of them are housewives and belonging to middle socioeconomic status, living in the joint family system, and living in the urban and semi-urban habitat. Among most of the participants, 61.6% of women had multiple complications, and 85.3% women had no current issues, and 85.5% women had previous complications during the pregnancy. 81.3% had not tested and not suspected to COVID-19 and not exposed to COVID-19. The total sample of only 2.6% women had severe level of anxiety, whereas 8.5% women had moderate level of anxiety. Fears also reported like women with risk coronavirus infection to the fetus, and risk of coronavirus infection during the pregnancy, risk of coronavirus during the labor, varies like 40.6% and 37.7% and 36.6%. Single characteristics were analyzed using the univariate analysis like chi-square test and t-test. Like these are the areas where been assessed, and I will tell you the table when the table is become. And multivariate analysis also assessed using the MANOVA and the regression analysis. The results have been shown significant. These results is a very strong basis of the study. Table shows that trimester, there are third semester participants has been shown 85.5%. Rest of them has been low, and Hindu religion participated most as well. And employment status, when you come to the employment status, most of the participant as a housewife, and most of the participant belongs to lower middle economic status. Many people are having the financial issues and staying in semi-urban and urban areas, stayed in a joint family system, and has there is a minimal level of abortion or stillbirth, and there is a complication in pregnancy has been less, and the complication previous pregnancy also less, and the past history of general medical illness also less. Past history of psychiatric illness also very less, 0.5%. In this table shows that there is a univariate analysis also associated and had relationship with religion area, like religion area and employment status and habitat, like domicile areas, as well as complications in pregnancy areas. Other than that, there is a multivariate analysis. Number one has been applied to the financial loss and complication in previous pregnancy and past psychiatric illness has been showed very good significant results. And in this table, there is a type 2 of multivariate analysis has been followed, and also shows that significant relationship in COVID-19 risk perception and antenatal COVID-19 anxiety. The areas of COVID-19 risk perception and antenatal COVID-19 anxiety. Multivariate analysis model 1 has been followed by using the MANOVA test. Model 2 has been followed by multiple regression model has been followed in these days. Discussion. 11.1% pregnant women who attended antenatal clinics found significant generalized anxiety among the study. Univariate analysis also had significant results with various areas, and mild level of anxiety was found 24.7%, and moderate severe anxiety found 11.1%. Already 35 researchers also had been collected in the supplementary article for literature purposes on writing the discussion also, and the past literature reviews of sample size suggested 11 to 4,000 in the population, and median score is median population is 300. So these studies approached 750 samples and they selected 620 samples. Many studies done with online surveys and Zhang self-rating scale of anxiety in the past and validity and reliability, especially lower income countries like India, other countries, other Asian countries, so the study has been selected generalized anxiety disorder scale. According to Kotabagi et al. In the year of 2020, study was done in the first wave of COVID-19, reported that mean scores of anxiety women also reduced, and this study also supported for this in the study. And according to Priest et al. In the year of 2020, suggested that assessing anxiety in pregnant women deemed not only to reduce vulnerability to stress, but also improve resilience among pregnant women, with possibility in opening of public limitation in India. After the lockdown, the greater sense of well-being and relief may have decreased anxiety rates. Additionally, the low rates of anxiety may have been influenced by Asia's relatively better COVID-19 relative outcomes. During the study period, as pandemic-driven restrictions were eased, the general population's fear of COVID-19 infection and risk perception decreased, and the social support networks began to reintegrate. However, despite these findings of the study demonstrated that generalized anxiety was significantly correlated with lower perceived social support, lower perceived COVID-19 risk, and higher antenatal COVID-19 anxiety. Generalized anxiety and COVID-19 infection during the pandemic, in the pandemic specific years, our factors have also been consistently linked in previous studies. Women may exhibit fewer precautionary behaviors during pregnancy if anxiety rates are lower and risk perception are lower. These actions are likely to increase the risk of adverse outcomes for pregnant women, especially in light of the rapidly expanding second wave of the COVID-19 pandemic in India. This study finding suggested that pregnant women who had previously or recently experienced pregnancy complications were more likely to be anxious. Previous research has found that significant correlations between antenatal anxiety and nulliparity being in the first or third trimester, higher education level, lower income, and employed status. Either some of these variables did not reach statistical significance in the multivariate model for predicting generalized anxiety in our investigation, or they were found to be significant only as correlates of antenatal COVID-19 specific anxiety. Further, research is needed to determine whether antenatal COVID-19 anxiety can act as a mediator between these variables and generalized anxiety. Strength of the study: one of the first study in India to assess anxiety in pregnant women during the COVID-19 with face-to-face interviews was conducted by trained interns with outcome of fair results. Assessed COVID-19 anxiety in pregnant women, pregnancy-related anxiety is a distinction for the study. Importantly, spreading the study's findings that pregnant women in India have low rates of anxiety might help prevent speculation and, as a result, sensitization of the pandemic's effects on mental health. Limitations of the study: this is a hospital-based correctional study and with a limited duration, 3 months. The study provides data from time when the pandemic was somewhat under control in the majority of the study locations and restrictions were lifted, possibly providing a sense of relative safety. In the second wave, the anxiety rates might be different. Improved vaccination rates may have reduced anxiety in the early months of 2021. However, the media's portrayal of rising daily case and death statistics, morbidity, a lack of hospital beds, and more virulent strains during the current second wave in India may have increased anxiety. Additionally, the study did not look at depressive symptoms, which could have affected anxiety levels. In addition, the finding generalizability is limited by the fact that the study sites were limited to a small number of states in India, based on resources and willingness to participate, and that some states with have high COVID-19 infection rates did not participate. Conclusion: during the pandemic period in India, when social and economic restriction has eased, but the incidence of COVID-19 cases remained high, the rates of moderate and severe generalized anxiety among pregnant women were found to be 11%. The rates of generalized anxiety were significantly influenced by antenatal COVID-19 anxiety, perception of COVID-19 risk, and a perceived social support. The findings of our study suggest that in addition to the fundamental need to incorporate screening for anxiety into existence antenatal program, it is also necessary to prioritize maternal mental health and provide pregnant women with psychological assistance in coping with secondary COVID-19 related mental health challenges. There is no financial support has been taken over in the study. There is no conflict of interest and there is no previous presentation before publication. References: the references were cited according to the journal's requirement. All the citations were correct. All the references cited were in text. Strobe checklist for the longitudinal, cross-sectional study. The study design is not mentioned in the title, but mentioned in the abstract. An informative and balanced summary of what was done and found has been mentioned. Introduction: background and rationale. The scientific background and rationale for the investigation reported was explained. Specific objectives were not stated, but an overall objective was stated. Methods: study design. Key elements of the study have been stated in the early in the paper. Setting, study location and periods of recruitment has been mentioned, and the relevant duration have been specified. The sampling has not been explained in detail, and the recruitment of patient was exactly done by past literature. Participants: the eligibility criteria has been outlined and method of selection has been mentioned. Methods: variables, outcomes, exposures, predictors, potential confounders, and effect modifiers has been mentioned. The diagnostic criteria has not been mentioned according to DSM-5 ICD-10. Data sources and measurement. Scales were used and mentioned with the translation procedures. Bias: no mention of efforts made to address potential sources of bias. Study size: how they arrived at the study size has been explained. Quantitative variables: which grouping was chosen and why has been explained. Everything has been mentioned. Statistical methods: for each variable of interest, groups were compared by chi-square test. For other categorical variable, univariate and multivariate model has been mentioned with the results. Results: participant mention of potentially eligible and confirmed eligible, no dropouts, no mention number of participants with missing data. Information on potential confounders exposure has been mentioned. Main results: unadjusted estimates, confounder adjusted estimates, their precision mentioned. Other analysis of other interaction also done. Discussion: key results have been summarized with reference study objectives. Limitation have been discussed account of potential bias or precision. Interpretation and overall interpretation of results considering objectives, limitations, Results from similar studies and other relevant evidence has been given. General accessibility commented with suitable examples. Other information, funding nil, financial support and sponsorship. Thank you.
Any questions, comments?
Stroke checklist used in general club. Whenever we going to do general club, whether it is a longitudinal study, cross-sectional study, there is a different checklist also available in the website. What are they included? What are they missed? We have to see.
Only general.
Sir, now case conceptualization.
This is a requirement.
Yes.
For cross-section studies, there is a checklist.
Yes.
So if you don't fulfill that checklist and submit to the journal, they will not accept it. So for every cross-sectional study, you need scope checklist. For case reports, there is another checklist. For online surveys, there is a checklist known as cherries. And for RCTs, there is a consort guidelines.
Yes, sir.
Journal club specifically